Hi everyone, this is Neil Wrighteter, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attends, I would say twice a year, but on this occasion, this left ear in particular was extremely impacted, and I did ask the patient whether they'd been poking in the ear, and they did say no to me, but there was some evidence there, as you may have seen. The lateral surface of the wax is an indentation, so just above where the suction probe is there, you can see it's quite a circular indentation. And what's that's done, it's really compressed the wax up against both side walls and the floor of the ear canal. The top, there's a slight gap there, and around the edge, it's really solidified. So I'm going to try and lift this off. It's rock solid. It's really crystallized, become crusted, whereas I would say the core of it was a bit softer, so it had two consistencies. Now guys, if you wait till the end of the video, I'm going to upload some still images of me using different visualization methods so it gives you an idea of the posture, the body posture and ergonomics involved. So at the end, I've got some still images of me using an ENT operating microscope. And this is with both the patient sat upright and also laid down on a couch, because there is two ways of performing the procedure. I typically have my patient sat up. Some people prefer patients laying down. So there is two different approaches there. So the first set of images is me using an operating ENT microscope. The second set of images is me wearing some head-worn head loops microscopes. The third set of images are me using the wax scope, and last but not least, the full set of images is me using the endoscope, the iClearScope device that I'm using here right now. So it'll give you an idea of the body posture, not only of myself, but for the patient, and it'll probably be quite an interesting thing for you guys to see. So do wait until the end of the video, and I'll talk you through all that. So I'm trying to lift this off the side canal walls, but it's really crusted. So I think I'm going to use the right correct now. What was great was the right, you can see the curvature there, it does mimic the curvature of the ear canal. And I was kind of lifting this off the canal wall, but the patient did find it slightly uncomfortable. As you can see, it is almost acting like a wallpaper stripper. It's coming away. But because it was so crusted, the patient did find it slightly uncomfortable. So I stopped there for a moment, and I'm just going to try and go over the top, which I managed to do. But I could feel the resistance at the floor of the ear canal, so that's where the problem was. I'm putting a lot of force through there, and it just wasn't coming away, and it was extending quite deep in the ear, quite medially towards the eardrum. So I'm just going to this posterior canal wall near the top. So this is classified as the posterior superior canal wall. I'm just trying to elevate this away, which I've managed to do. Now, although I didn't remove the wax in its entirety using the correct, and I also used the Rye pick a bit later, and with the Rye pick, ear pick, you'll see the difference in consistency. So this superficial surface of the wax plug was quite dry and crusted, but the core was soft, and you'll see that with the ear pick. So I managed to leverage that forwards, and I'm starting to break down the adhesions against the canal wall. So yeah, although I didn't manage to remove it using the Riker, it really did help loosen the wax plug. So when I used the suction a bit later, it came away a lot easier. So this is becoming a bit softer now, this core bit, so it's not coming away in one piece, unfortunately. And you can see it's almost smothering this soft wax instead of coming away, it's spreading it. So I think I'm going to go to the front part of the ear canal now, just to see if I can elevate this crusted section here. And again, I did get in between, as you can see, and it is coming away. So the patient did find it slightly uncomfortable. You see the ear canals are quite red anyway. They've got a bit of superficial otitis externa, a chronic condition they're suffering from. I was reluctant to use any drops for this, just purely because the patient is a hearing aid wearer, and they were obviously intending to wear the hearing aid as they leave. And if I had loads of drops, sometimes it's unavoidable, and I was contemplating, but we did manage to remove it without the drops. It would have potentially, the drops may have infiltrated the hearing aid, the sound bore, and caused some damage. So I was trying to resist that. So again, I'm just trying to use the loop now in the curette, just to kind of see if I can almost circle around some wax to remove it. I'm trying to think of the phrase. It's completely, my mind's gone blank. But in the movies, when the cowboys they have their rope and they're swinging it over their head, and to capture their cattle. Similar, I was just using the center of the curette in that same manner. I was trying to get a wax piece in the middle and then kind of leverage it out. So I've just gone back to the suction here. And I think I'm going to use the rye pick in a moment, but it's here at the bottom where it's really crusted. So there, the floor of the ear canal is quite a narrow valley there. Even with the rye curette, although I've got that curvature, it was difficult to glide it through the floor of the ear canal. Now with the rye curette, what's really good is the more distal end, so the furthest point away from us, it is a narrow and pointed. So it's not, I've designed it in such a way that it's not a round, completely round sphere. So that, although it didn't manage to loosen it, it wasn't uncomfortable for the patient, that section, because it was able to get some into that valley, so to speak. So with the right ear pick, I was trying to embed it into the core, which I have. And then if it was solid all the way through, as I'm dragging it, it would all come away. But it wasn't. It was quite soft and mushy in the center. And I think you'll have a better perspective of that in a moment. So you can see it's quite smudgy and fudgy. There we are. That gives you a good representation. So yeah, so it's too soft basically, so it's not going to come away in large chunks with the right pick. So I'm going to revert back to the suction. However, even at this stage, the patient felt they could hear better. They did mention that they felt the sound was going through a lot better, but the core of the wax is still there. So I'm just trying to lift it away, and now I've got some good purchase. I'm going to give it a little wriggle just to separate it from that bottom section, because I'm going to go back for that. Some of it did come away, but there was a bit of residual crusted wax at the floor that was quite stubborn. That's the patient's eardrum, nice and healthy. You can see that the ear canal is a bit red with erythema there. So they have been prescribed some, I think actually they were prescribed not Otomize, which is 3 active ingredients. It's got acetic acid. So the acetic acid helps to reacidify the ear. It's also got some drying components. So if you've got a bit of moisture in the ear canal, acetic acid can help kind of dry up the ear slightly. Otomize in the UK, it's also got an aminoglycoside antibiotic called neomycin. So they inhibit the reproduction of pathogenic bacteria, well, of all bacteria really. And it also contains dexamethasone, which is a steroid, so it's anti-inflammatory benefits. Again, I'm just going to use that center section of the rye curette just to get some of these crusted bits away. Worked pretty well there, but I think in the end I'm just going to use the vacuum just to remove it. So this is really, really stubborn, this section here. So I'm trying to go around it over the top and then slowly come towards myself to remove it. So it's just coming away in flakes, still embedded and attached to the floor of the ear canal. And ultimately I'm going to use the fine end, and I'm just going to have to apply a bit of pressure, but we've got to be careful. We don't want to lacerate the canal wall or ulcerate the skin. So as I'm gliding, I'm just gliding over the surface. We don't want to, it's be quite easy to scratch the ear canal here, so I'm pretty pleased with that. And the reason why I was going for that is the patient did still find the ears quite itchy. No doubt all this crusted skin is not going to help. and it's just a bit here. So we are on the bony part of the ear canal, so we do got to be gentle. The bony part of the ear canal is extremely sensitive. It's literally skin on bone, and that skin itself is 0.1 millimeters in thickness. There's no dermis layer there. It's only the epidermis layer. There's no fatty layer, so the subcutaneous layer. There's no muscle there. So it's just skin on bone. And the best way I can describe the sensation, if you make fierce contact with the bony part of the ear canal, is if you knock your shin bone against the side of the door or something like similar. It's a very sharp, acute pain, and I know because I've had trauma to my ears before. My mum, when I was growing up, regularly every weekend, used to clean my ears out with Q-tips, or so she believes she was cleaning my ears out with Q-tip. In fact, it was just making it worse, and on one occasion, it was my left side. Still, even when I think about it, I can still envisage and remember the pain that was inflicted. It was the back part of my ear canal. It was very sharp, prod and poke against it on the bony part, and that ear's always been a bit sensitive since. So I'm going to be really, really gentle. Don't want to leave the patient with any negative experience of their visit to have their ears cleaned. So it's a fine balance. Sometimes you've got to know when to stop, but at the same time, you want to make sure you're doing as much as you can safely as possible to help the patient with their symptoms. So you can imagine if a patient's complaining of really itchy ears and you've got this crusted skin, you want to try your best to remove as much as possible for them. So that's the patient's eardrum, nice and healthy, and I'm going to move on to the right side. So I wouldn't say this was as occluding, you can see half the eardrum there, but it was extremely dry this side, strongly adhered. So you can already see the colour of the canal is not as red, so there's less erythema of this side, which just means redness basically, caused by the blood vessels dilating. And here it's much more dry. It's like shards of glass almost. So every time the patient, they were saying when they move their jaw, they're feeling their ears to be really itchy, and you can imagine why. This is going to, it's almost like I've got a sandpaper surface, and it's rubbing against the canal walls. And managed to get the main occluding piece out there. So the eardrum's fully visible, and again, just going to spend a bit of time now just peeling this away from the canal wall. See just how dry this skin. So this is keratinous epithelial skin. So it's this most superficial layer of the epidermis, stratum corneum, and found on this outermost layer you get sublayers of this epithelial skin cells, and they're like flat cells, and they're interlinked. It's like body armor in medieval times. And when they reach the outer layer of the epidermis, these skin cells are dead. They've got no nucleus. It's metabolically inactive. Instead of having all the intracellular fluid and all the organelles, it's filled with keratin in little bundles. And the keratin itself, which is a protein also found in our hair and fingernails, it arranges itself underneath the cell membrane in a rigid zigzag consistency and formation, and that provides the skin cells at the surface additional strength, because imagine, so our bodies, the outer layer of our skin is all full of this keratinizing skin, and you need that toughness because that outer layer skin goes through a lot of trauma during the course of the day. So it needs that rigidity and strength, and that's what the keratin provides. Keratin is also predominantly hydrophobic. So when I say predominantly, it's weird. So I was doing some more reading about keratin. It's 40% hydrophilic and 60% hydrophobic. So overall, it's an hydrophobic molecule protein. So it does help to repel water, excessive water, but it also inside these skin cells, and this is where the molecular balance of the not on, I'm sure the ear, but all parts of the body. It's just really fascinating and amazing. So the outer layer of skin, this epidermis layer, it needs some moisture, of course, to hydrate it. Otherwise, all of our skins will be really dry and cracked. And you've got these natural moisturizing factors found within these skin cells, which also contain keratin, and they're hydrophilic, so they're water attracting, and they're hygroscopic, so they swell when they're exposed to water. So you have free amino acids, carboxylic acids, urea acid, and these are all hydrophilic molecules. So you've got these natural moisturizing factors that are trying to absorb moisture, and then you've got this keratin at the same time trying to repel water. So it kind of restricts how much water can be absorbed, but nonetheless the skin cells can absorb, I think, up to 30 times its own weight. And if the skin cells are exposed to too much water, then the skin cells will overhydrate, and when they overhydrate, the skin cells will expand and swell, and they'll break down at the membrane, and that leads to the maceration of the skin. And once the outer layer of skin, the epidermis, is macerated, it exposes the inner layer, so all the skin flora, all the bacteria, fungi at the surface can then penetrate into the deeper layers of the skin and potentially cause an infection. So it's just amazing how the skin cell has evolved to just absorb enough moisture in the air. So it's moisture in the air that it can attract. So you don't have to get water in your ear. If you get water in your ear, you're going to potentially overhydrate it. And so it's a lot of the earwax softening drops. You got the oil-based drops, but the oil-based drops are just designed. They don't fragment the wax plug. They just soften the surface and loosen it and give some lubrication against the canal wall. But most of the other ones, they are water-based. And so with sodium bicarbonate drops and hydrogen peroxide drops, they cause an effervescence when they enter the ear. So sodium bicarbonate drops, they react with the carboxylic acid, which is found in sebum, which is the oily sweat, but it's also found in the skin cells, because I said that carboxylic acid is one of the natural moisturizing factors. And so when sodium bicarbonate drops reacts with the carboxylic acid, it converts into water and carbon dioxide. And when you get the bubbling formation of the carbon dioxide, that helps to fragment the wax plug. But water is then absorbed by the skin cells, and then it swells and expands. But so remember, a wax plug it contains loads of corneocytes, these dead skin cells. So water is actively used in these water-based drops to break it down. And similar with hydrogen peroxide, that reacts with a catalase enzyme called peroxidase that is secreted by the ceremonous glands. And when it does, hydrogen peroxide converts into water and oxygen. So when it converts into oxygen, you get that effervescence, the bubbling, and that helps to fragment the wax plug. But the water component is absorbed by these corneocytes that overswell, overhydrate the skin cells, which then burst. Something like Armageddon. This water gets absorbed into the core of the wax plug and it explodes. Like with Armageddon, they wanted to blow up the meteorite from the core, and that's what these drops do. So these are the still images I promised earlier. So this is me using an ENT microscope. The glamorous assistant is Dharma, who's Clearwax's business development manager. She kindly volunteered. So the ENT microscope, this is with Dharma laying down. So you have you can see that it does require a lot of extension of both my hands, and my head's in a forward position, head's down posture, almost looking into the microscope. This is me using head-worn microscopes, loupes, and because of the really low magnification and reduced focal depth, I had to really lean forwards, almost like a head forwards posture, just to visualize what's going on, and that did put a lot of strain on my neck. This is me using the wax scope. I felt a lot more relaxed, as you can see, and I've got a good operating length, so I'm not too close or too far. It does require a bit. It does strain your non-dominant hand when because you're holding the device. This is the iClearScope. This is what I'm normally using. This is what the device I used in the procedure today. So it does require a lot of work from your non-dominant forehand because you're holding the device itself. Well, hope you found that interesting. Take care, guys. Keep well and speak soon. Bye.